Since the discovery of CPR in the 1950s, much has been learned about resuscitation physiology. The increased knowledge about how blood moves and the negative effect of ventilation has resulted in some dramatic improvements in resuscitation. For decades, there was very little appreciation of how ventilation impacted the overall effectiveness of CPR. Overventilation causes a decrease in cardiac preload and decreases blood flow during CPR. In head-injured patients, overventilation can cause respiratory alkalosis, increased intracranial pressure, and increased brain ischemia. One paper by Ofterheide et al. Published in Circulation in 2004 helped to bring the problem of hyperventilation and failed resuscitations into focus. Rescuers were studied to determine their actual ventilation rates in field practice. The observations were startling. Patients were routinely ventilated at rates of over 30 times per minute. Even after retraining, these experienced rescuers only slowed their rates to 20 times per minute. In the animal lab, only 1 of 7 pigs that were hyperventilated survived. Of the pigs that had controlled ventilation, 6 of 7 survived. It became clear that increased emphasis needed to be placed on slower and more controlled ventilations to improve resuscitation outcomes. Since 2005, AHA guidelines called for ventilation volumes to be limited to 6 to 7 milliliters per kilogram, and that ventilations be given over 1 second to decrease airway pressure, and the rate reduced to about 10 times per minute. Today, many EMS systems emphasize the use of supraglottic airways during resuscitation. When using these devices, ventilation volumes and pressures must still be tightly controlled. Supraglottic airways do not prevent gastric insufflation or prevent regurgitation. Given that EMS providers are highly trained and skilled, the question must be asked, why do medics lose control of ventilations during a resuscitation? Even the best organized resuscitation efforts can create a sensory overload and cause rescuers to become distracted. In many cases, rescuers are so overtasked that a bystander or a minimally trained rescuer is assigned the critical task of ventilation. Plus, advanced airways of all types allow for easy runaway ventilation. In overcoming quality issues, there is no substitute for having policies and procedures, training, and having technology to help overcome clinical issues. Policies and procedures and having the discipline to follow them can make a big difference. One policy being developed to enhance resuscitations is the NASCAR pit crew approach. Policies and procedures are developed to tightly define roles during a resuscitation. Rescuers are trained to work as a team in well-defined roles. Training in policies and procedures is another key element in ensuring compliance. Training on mannequins in a ventilation training analyzer helps provide immediate feedback when manual ventilation is inadequate or so forceful that gastric insufflation is occurring. Technology is another method of overcoming quality improvement issues. Controlling manual ventilation isn't easy, as most bag valve mask devices do not provide rescuers with any control or feedback. One simple device that helps overcome these problems is the Smart Bag. It's equipped with a flow restrictor that prevents a rescuer from squeezing the resuscitation bag too forcefully. If the bag is being squeezed correctly, the bag is easy to squeeze. If a rescuer attempts to squeeze the bag too forcefully, the flow restrictor engages and reduces the flow to less than 40 liters per minute. It can also be equipped with a timing light to prompt the rescuer on the correct rate. Simple handheld automatic transport ventilators allow rescuers to rapidly set rate and volume. They consistently deliver the proper inspiratory-expiratory ratio and deliver precise ventilations in terms of rate, volume, and force. Combined with a simple disposable circuit, they provide hands-free, precise ventilation when an advanced airway is being used. In addition to devices, ventilation and oxygenation should be guided by waveform capnography and pulse oximetry. Ventilations must be carefully titrated to an appropriate end-tidal carbon dioxide and oxygen saturation level. The titration must be carefully delivered to prevent a seesaw effect of over and under ventilation while attempting to maintain end-tidal carbon dioxide levels within range. Resuscitation success depends on controlling both ventilation and circulation. While ventilation was once presumed to be simple and uncomplicated, research has helped us understand that more isn't necessarily better and that ventilations must be tightly controlled. To achieve optimal ventilation and oxygenation requires policies, training, and technology to prevent patients from being bagged to death.